Welcome to Medic's Desk. Today we'll be studying about Bortezomib. Bortezomib is a reversible 26S proteasome inhibitor. Proteasome has a function to degrade the ubiquitinated proteins into the body. So when there is an inhibition of proteasome, there will be accumulation of such abnormal proteins into the cell, and it will lead to apoptosis of the cell. So due to this, there is an altered regulatory proteins into the cell, and the cell cycle is impaired, and it undergoes arrest in a G2M phase. There is also altered activation of NFK beta pathway. This is basically a cell, and these are the abnormal proteins. They undergo ubiquitination. Whatever dotted structures we are seeing is the ubiquitination of the protein. It's basically a spicing up of protein before they undergo degradation. This is a proteasome, and we can see this is a 19S cap and 20S core. So this abnormal protein, they enter from the 19S cap and they are degraded into smaller proteins. What bortezomib does is it inhibits this step. So there will be accumulation of all these abnormal large proteins leading to cell death. Coming to the pharmacokinetics of the drug, it is metabolized in liver mainly by the microenzyme CYP3A4 and 2C19. In any moderate to severe liver impairment, there is increased area under the curve will increase by 60%. It means seen due to impaired liver function, 60% of the drug is retained by the body due to impaired metabolism. So what special precautions we have to take giving this drug? We have to take a caution that if any person who is having hypersensitivity to boron, this drug cannot be given to the patient. And in patients, it can cause HBV reactivation. So every patient who is receiving bortezomib, they should be tested for HBsAg and anti-HBc total both. And if anyone is positive, then they have to be treated for entire duration of their chemotherapy. LFT and HBV DNA to be tested every 2 monthly. It also causes reactivation of herpes zoster. So they should be given a prophylaxis of valacyclovir. It increases the risk of peripheral neuropathy, so should be used cautiously. Any overdosage, that is a drug which is given twice, 2 times or 3 times of its normal value, can lead to hypotension, thrombocytopenia, and it can also lead to fatal outcomes. In special populations like diabetic who are receiving oral hypoglycemic agents, bortezomib can cause hypo or hyperglycemia, so their blood sugar should be carefully monitored. In patients who are having amyloidosis, this drug should be used with caution because there is accumulation of abnormal proteins. So what exactly this will do in amyloidosis is not known. Hence, it should be used cautiously. Any patient who is having hypertension and is on antihypertensives, this drug should be used very cautiously because it can lead to increase the risk of hypotension. So there can be some dose adjustment that would be necessary before we give antihypertensives. This can also cause potential life-threatening transfusion-related GVHD in previously treated myelomas who has undergone a transplant. So all the patient who has undergone transplant, we have to give only irradiated blood products. Coming to the route of administration, this can be administered either subcutaneously or IV administration, but it has been noted that even subcutaneous administration has got a comparable effects as compared to IV administration. So when we give it subcutaneously, we note that there is a systemic availability and overall response that is same as the IV administration. Along with this, it also has been noted there is an increased safety profile and decreased chances of peripheral neuropathy in subcutaneous administration. Only a common side effect that is noted is a reversible redness at the site of administration. Coming to the main side effect of the drug, peripheral neuropathy is one of the most important and dose limiting side effect of bortezomib. The peripheral neuropathy is mainly sensory and is characterized by pain, paresthesia, numbness. These findings are more in feet as compared to hand. What exactly is the mechanism of peripheral neuropathy is unknown. The patients who are having a baseline symptoms of like they are diabetic or having any other neuropathy initially, they are at more risk of developing severe neuropathies. So what we have to do is to detect them early, and appropriate dosage to prevent the development of severe neuropathy is important. Bortezomib can also cause autonomic neuropathy, which can lead to postural hypotension, diarrhea, constipation with ileus, and pyrexia has to be remembered. So, what drug dosage to be given in peripheral neuropathy is given by NCI guidelines. So, these are the NCI grades and these are the dosages. Suppose the patient is having grade 1 peripheral neuropathy without any pain or loss of function, we have to maintain the same dose. But a patient with grade 1 neuropathy with pain or grade 2 neuropathy, they have to be given a dose which has to be reduced by 25%. In patients with grade 2 with pain and grade 3, we have to withhold until the symptoms have resolved, and upon stabilization we have to give the drug at a dose of 0.7 mg per meter square. When patients develop grade 4 neuropathy, we have to discontinue the drug. Coming to another important side effect, that is thrombocytopenia. It is very commonly found in all the patients of multiple myeloma receiving bortezomib. So median almost 60% of the patient, they are noted to have decrease in their platelet count regardless of their initial count. There is also decrease in the baseline myeloma protein and some degree of bone marrow involvement. So thrombocytopenia is generally noted after cycle 1 or cycle 2, and it continues throughout the therapy. But there is no evidence that there is a cumulative thrombocytopenia in the further cycles. The platelet nadir, it comes basically on day 11 and it rises to normal on day 21, has to be noted. In responding patients, platelet count at baseline, it appears to increase progressively from second cycle onwards. The mechanism of action is exactly unknown what is happening, but it is unlikely to be related to bone marrow injury or decrease in thrombopoietin levels. Hence, only supportive care is necessary. But in patients who are having platelet count of less than 25,000, there should be temporary discontinuation of the treatment. There are also some reports that show on receiving bortezomib, patient has developed GI or IC bleeds, that is drug-induced thrombocytopenia leading to fatal complications. Let's see other side effects. Diarrhea is also one of the common side effects that is noted with bortezomib, and severe diarrhea is seen in around 7 to 8% of the patients. Diarrhea is managed with adequate fluids and loperamide. But before giving loperamide, we must rule out C. diff infections, and then we should use loperamide. As this patient, they will lose lot of electrolytes. Electrolyte replacement is must in this patient. But though they develop diarrhea, the pre-medication with loperamide is not needed in all patients, or it is not at all recommended in any of the protocols. If any patient who has not tolerated bortezomib well, loperamide can be kept as a standby medication for the next cycle. In grade 3 NCI diarrhea with mucus or dehydration, that we can discontinue the treatment until recovery of the patient, and we can reinitiate the dose at a 25% of the original dose. So we will see the NCI grades of diarrhea and what dose has to be given. Suppose a patient is having less than or equal to 2 grade NCI diarrhea with 4 to 6 loose stools per day or more, there has to be no change in the dosage of bortezomib. But a patient who is having more than or equal to grade 3 diarrhea, that is 7 to 9 stools per day or more, with mucus or dehydration, the dose has to be decreased to 20 to 25%. Coming to other side effect, that is hypotension. So almost 12% of the patient, they develop this symptom, and the risk factors that has been seen in this patient generally are there is any previous history of syncope, any concomitant any BP medication that is going on, any previous dehydration. So before giving bortezomib, we must check what is the hydration status of the patient, especially if the patient has got any vomiting or diarrhea. If a patient develops hypotension, they can be treated with mineralocorticoids or sympathomimetics, and they respond very urgently, very fast in the this side effect. In grade 3 hypotension, we must discontinue bortezomib until the symptoms have resolved and to reinitiate the dose at 25% of the whatever original dose was given. Liver failure is a rare side effect of bortezomib, but if bortezomib is given concomitantly with other drugs in serious underlying conditions, it has been noted that there are some people they develop liver failure. Patients can develop asymptomatic hyperbilirubinemia, transaminitis, and hepatitis that is associated with bortezomib. This side effect can be reversible on discontinuation of the drug. The liver function returns to normal. Patients also develop tumor lysis syndrome due to breakdown of the tumor cell if the tumor burden is high. Just coming to other important side effects. It causes bone marrow suppression that we have seen, and patient develop anemia, neutropenia, and thrombocytopenia. Some people they also develop constitutional symptoms like fatigue, fever, insomnia, and rigors. There can be some dermatological side effects which are noted with the bortezomib are rash, urticaria, and pruritus. GI side effects are common. Generally, patients develop anorexia, constipation, dyspepsia, nausea, and dysgeusia. Important side effect diarrhea we have already covered. Some patients may also go epistaxis due to underlying thrombocytopenia. Pulmonary side effects like cough and dyspnea can also be seen around 20 to 30% of the patient. So just to revise it in a crisp, bortezomib, it's a proteosome inhibitor. It causes inhibition of the degradation of the ubiquitinated proteins, leading to their accumulation and causing cell death. So bortezomib, to revise, it induces apoptosis, it inhibits growth and survival, inhibits DNA repair, impairs the cell cycle. It has got anti-angiogenic activity. It is anti-osteoclastic. It adapts to the bone marrow microenvironment and induces proteolytic stress. Thank you and see you in the next class.